Welcome to our public lecture series. It's my pleasure to introduce Professor Christina McKean. She actually exemplifies what our department stands for. We are a multidisciplinary department, and Christina comes from the field of allied health. She's a speech and language therapist, much accomplished as you can imagine, but I'd like to introduce some of her main sort of high points of her career. She is the senior academic research leader in our department for special education and child development. She's professor of child language development and disorders, a fellow of the Royal College of Speech and Language Therapists. She's also an honorary research fellow at the Murdoch Children's Research Institute in Melbourne. She does quite a lot of work in Australia. She has other international collaborations, particularly in the Middle East. She was earlier the editor-in-chief for the International Journal of Language and Communication Disorders. I was looking up the brief of this particular journal, and it almost echoes part of Christina's career. It is a mixture of quant and qual research, quantitative and qualitative research. It is interested in applying evidence to practice and is focused on therapy and pathology, but also on mainstream development. And Christina's research has straddled all of that. There are 4 key themes in Christina's work, one of which is individual differences in language development and the trajectories of language development, particularly from the early years into middle school. Children who are at risk. This is something that has been a sort of leitmotif of a lot of Christina's publishing. She's done a lot of work in the area of developing and evaluating interventions, particularly early years interventions. And she has a very strong research focus on cross-sectoral work and service provision. And I think we might hear more on that in today's lecture. So welcome, and over to you.
Thank you very much indeed. Thank you. It's almost delivered the précis of my lecture, so we can all just go and have a drink now. But thank you very much. So yeah, thank you for that really kind introduction. It's a real honour and a privilege to be here today delivering my inaugural lecture at the Department of Education in Oxford. Thank you to everyone for attending. It's really lovely to see so many people coming at the end of a long day. So thank you for making the time, and also lots of people online, and I'm recognising familiar names on there, which is really lovely. Thank you for coming. So this talk is going to last about 50 minutes. So if you can hang in there, then we'll get a reward of a nice drink of something at the end of there, and perhaps some nibbles as well. So hang in with me for 50 minutes if it's interesting. So as you said, Shonali, the department's got a really long history of multidisciplinary work, but I believe I am the first speech and language therapist to be appointed in the department. And so I'm really proud and excited to bring the speech and language therapist's perspective to the wonderful work that happens here. The focus of my lecture today is a challenge which necessarily invokes a multidisciplinary response. And that's, how do we, as families, communities, practitioners, services and policymakers, meet the challenge of creating the conditions for all children to have robust early language development? So to get us started, I just wanted to talk about why should we focus on early language development. So anyone who's spent extended periods of time with infants, toddlers and preschoolers can't fail to be struck by the almost miraculous journey which children take from birth to school entry in their language and communication skills. So from cooing and babbling to first words and sentences, through to asking many, many questions and sharing jokes and stories. This process is a really enjoyable one to participate in as a parent or a practitioner, and it's one of the most impressive developmental achievements of early childhood. However, not all children take this developmental journey at a similar rate. There are substantial individual differences in children's language progress over the first years of life, with around 8% of children having persisting difficulties with learning language, which can affect their learning and their social relationships. And also which have long-term consequences across the lifespan for those individuals. So language is a really vital foundational skill for young children. And why the focus on early language development and not language development across all of the child's development? So language development in the early years really sets the stage for individuals' education, health and well-being into adulthood. It's sort of obvious that that's the case because it's the medium through which we learn, build relationships and make sense of the world and process our emotions. And if children enter school with low language abilities, the consequences can be really profound, significantly affecting their life chances well into adulthood in terms of education, employment, mental health and social inclusion. And the early years represent a period of sensitivity to environmental experiences, a really sensitive period where children can benefit the most from enabling exposures or are disadvantaged the most by risk exposures, more than any other time in the life course. And that's why if children enter school with low language abilities, the consequences really can be profound for them. Furthermore, the promotion of robust language development in these early years bring about greater returns over the life course. So if we can get it right in these critical period, through the process of developmental cascades across childhoods, earlier skills support the development of later skills. And so we can get larger returns on the benefits if we can support children in these very early years. So, although early support to ensure all children have robust language skills in the early years is therefore really logical and a clear priority, it's not really straightforward to do. It's more difficult than you might imagine to make this happen in the early years. And there have been several challenges and gaps in our knowledge which have made the design of systems of early support to promote robust language development really difficult. And these include these 4 challenges, which Shonali outlined for you, underpin the work that I do. So these include gaps in our understanding of the nature and the drivers of individual differences in children's language trajectories, difficulties with creating methods for identifying children at risk at an individual level, gaps in the evidence regarding the development of effective interventions, and a lack of knowledge regarding the design and provision of equitable and effective services. And so in the following lecture, I'm going to describe some aspects of a body of work which we've completed, which aims to understand those differences, drivers, interventions and systems, and then go on to outline a public health framework that has developed from this work and been driven by that work, and then finish with some detail about where it is that we're going next. So before I begin, I just wanted to acknowledge that, as I think I said to somebody in this room, I'm a demon collaborator. So all of the work that I do is completed in collaboration with others. I've been privileged to have really long-standing collaborative relationships with several really amazing people, and some of whom are pictured here. I don't have the time to name them all, but I did want to make sure to acknowledge them, and in particular to acknowledge my amazing mentors, Professor James Law and Professor Sheena Riley, who've opened so many doors for me in my career. So now, considering the first challenge and gap in knowledge, which relates to the nature and drivers of individual differences in development in the early years. So in 2013, I was appointed to a postdoctoral position at the Centre of Research Excellence in Child Language, which was led by Professor Sheena Riley, one of my amazing mentors. And this was at the Murdoch Children's Research Institute in Melbourne. One of the core aims of the Centre of Research Excellence was to look to leverage existing longitudinal data to answer some of the questions that we have about children's language development. A unique resource, which I was able to leverage in this way as part of my postdoctoral work and ever since, in fact, is the Early Language in Victoria study, or the ELVS cohort. So this unique resource, as I say, is unique because it's a cohort of 1,910 children, where the gold standard language measure for children's particular age is measured at almost all of the data points that along the time points in the cohort, and that's incredibly rare in longitudinal cohorts. And it's also unique in that it's a population sample rather than a clinical sample, which is often the case in language cohorts. So, as I said, this unique cohort of 1,910 children measures a range of child and family factors repeatedly from 8 months to 21 years alongside language as well. And so it provides us with the ability to understand the nature and the drivers of individual differences in children's development in the early years and into adulthood. And importantly, it's one of very few data sets which measures language in the under fives. It's very rare to have that data, so it's great data to play with. So using this cohort, we were able to demonstrate that there's really high volatility in preschool children's language trajectories. So looking here, for example, at 4 years of age, 11% of children in this cohort had low language abilities by the time they were 4. But just over half of this, just less than half of this impaired group were actually late talkers at 2. And just over half of the impaired group at 4, this 6% of the whole cohort, looked like they were doing absolutely fine at 2 years of age. And similarly, of the 19% of children who were late talkers, almost 3/4 of them were doing absolutely fine by the time they were 4. So these patterns of volatility or instability create real challenges for the provision of intervention. So if we were to provide support based only on language abilities at 2, we would potentially both be over identifying and over servicing children, but also under identifying and under servicing children. So we went on then to look at the nature of subgroups in children's trajectories over time. Excuse me, I spent time with my granddaughter and she's brought me some lovely germs over the weekend. Excuse me. So when we examined subgroups in children's trajectories over time between 4 and 11 years, however, we found that there was much greater stability once we got to this age range. So 94% of children had a stable trajectory between 4 and 11 years. So this suggests by the age of 4, we can be quite confident which children will have persisting difficulties. And so we can target resources to support based on assessing children's language abilities. And in fact, if we do find children with low language at 4 years of age, we really ought to be getting in there and doing something about it, because these children are likely to have persisting problems. So this stability, although it's a really helpful thing for identification, it does underscore again the vital importance of the very early years up to the age of 4. There's a hugely wide-ranging language abilities at the age of 4 years, and these substantial individual differences have emerged and been shaped by the child's first 4 years of life. So therefore, these first 4 years are vital, important, because from 4 to 11, a child's relative position in their language abilities is relatively fixed. And so we really need to be looking earlier to see if we can make significant differences for children's language outcomes. So what might be driving these individual differences? Well, there's a clear social gradient in children's language abilities. And so socio-economic circumstances must be playing a role. So here we can see this gradient associated with quintiles of disadvantage here is present in the Millennium cohort, the Growing Up in Scotland cohort, and in ELVS, although to slightly differing degrees. And we found it also in German cohorts and cohorts in the Netherlands. So it's been suggested that of all the socio-economic inequalities in child health and development, that language, none is larger than those related to language. So any approaches to early language development must consider the social determinants of these inequalities. So the gradient is such that on average, 8% of children have persisting difficulties with language, but in some of the most disadvantaged areas and classrooms in the UK, this can rise to up to 40% of children. And I think this is a figure which I'm sure many early years practitioners can relate to in their settings, particularly post-COVID. So how might social disadvantage be playing out in families? So we know that structural inequalities make it harder for families living with social disadvantage to provide enriching early years environments for their children, both at home and in terms of access to quality early education and care. And we know that socially disadvantaged families rarely experience individual risks in isolation. As a colleague of mine described it, she said risk factors hunt in packs. And I think she's absolutely correct that within families, if you have one risk factor, you're much more likely to have other risk factors. So we recently conducted analysis to consider how exposures which can influence children's language outcomes might cluster together or might accumulate over the first 4 years of life. And we considered 16 different early risk factors here and risk exposures. And we first looked at whether the number of risks that children had in their lives were making a difference. So we're thinking about this idea of accumulation, first of all. So perhaps unsurprisingly, when compared to children with just 0 to 2 risk exposures, each additional risk exposure that the children were exposed to increased their likelihood of having language difficulties, this time at 7 years of age. So we weren't surprised to find that, but we were perhaps a little bit surprised by the magnitude of the differences that we found. So, for example, if a child has 5 risks, then they were 7 times more likely to have language difficulties at the age of 7. And if they had 6 or more, they were 17 times more likely to have language difficulties at the age of 7. So I think if we imagine families, certainly I can imagine families who I've worked with in practice who definitely would have multiple risk factors happening in their lives. So then we went on to think about how do these risk factors cluster together, to think about whether there are certain patterns of clustering which make it more or less likely for children to have language difficulties. And we found 3 groups that had an increased risk when we looked at this clustering, increased risk of having language difficulties. The group with the highest level of risk of having language difficulties was a group where there was clustering of the children having vulnerabilities in their development and vulnerabilities in the home learning environment. So, for example, where a child was slower to use gesture in their communication, and where families had few books in the home and low levels of parental responsiveness, that clustering was most likely for the children to have language difficulties by the time the children were 7. The next most at-risk group, as it were, had high levels of social disadvantage, which were also clustering with vulnerabilities in the home learning environment. So not only did the families have low socio-economic circumstances, they also were finding it difficult to provide language enriching environments within the home. And the third most likely group to have low language difficulties was one where there was high levels of maternal mental health difficulties, and also the children had high levels of social, emotional and behavioural difficulties as well. So that was the third cluster. So these analyses, I think, go some way to explaining how and why social disadvantage and individual family circumstances may be playing out to affect children's language development. Okay. So another study that I just wanted to highlight when thinking about the natures and drivers of individual differences is a more recent study that we've looked at thinking about the accumulation of positive or negative exposures over the course of the early years. So in a recent analysis, we found that where parents and caregivers were consistently using responsive communication with their children at 12 months, 2 years and 3 years, then better language outcomes were found at age 7 years than when inconsistent use was there. So clearly, it will be harder for families with more disrupted living circumstances to be consistent in this kind of way over the early years. So, for example, that subgroup we described previously with high levels of maternal mental health difficulties, I think we could clearly imagine that this would be much harder for them to provide this consistency of responsive parenting and with subsequent consequences for children's early lives. So as well as identifying risks, I think this highlights the need for ongoing and consistent support to families in this vital early period of children's development. Okay, so now moving to the identification of children at risk. How might we use this knowledge to help us to identify children who might benefit from support? So from the work that I described, it's clear that in the very early years, we can't rely just on language skills to identify children at risk because of that volatility that we talked about. But also we know that there's a number of key exposures in children's lives which might make them more likely to have language difficulties. So we looked again at the ELVS cohort, and this time we looked between 12 months and 4 years, and we asked, can we build a kind of a risk model to judge individual levels of risks between 12 months and 4 years? So we asked, what are the most powerful child, family and parental predictors that we can measure at 12 months of age, which will predict how children are doing at 4 when we know that we've got this stable trajectory in place. And we chose factors within the ELVS cohort that we believed that practitioners would be able to find out in their practice. So they weren't things that would be difficult to measure or completely out with the possibility of a practitioner to use. And so we wanted to find these factors within routine practice, and we identified these 7 predictors. So at the level of the child, they were whether or not the child was showing objects. I think so these will be very familiar to people. The numbers of words or phrases that children understand and the words that they use meaningfully. And at the level of the family, we found that whether or not the family had a family history of literacy difficulties or language difficulties was also a really important predictor, as was the level of maternal education and socio-economic status of the family. And importantly, we found that the inclusion of this one question at the bottom here significantly improved the model. So parents were asked to indicate whether or not they said, when my child plays with a toy, I talk about it sometimes, often or never. And we found the addition of this question, I'm really surprised that people answer never, but some people do answer never. And the addition of this question into the model significantly increased its predictive validity. And so we felt that this was interesting, and we found that this model was more accurate than that late talker status at 2 years of age. So these early factors at 12 months were more accurate than late talker status. And we were interested in thinking about whether this provided us with an opportunity of a larger developmental window for intervention, so getting in earlier, getting in at 12 months to support families than measured at 2 years. And we also really liked the idea of this question at the end, which had the potential maybe to open up a kind of therapeutic conversation with parents about what it is that they might be able to do to support their child. Obviously, this isn't the real life, this is in a cohort, but we'll come to real life in a minute. My colleague, also thinking about identification of children at risk, my colleague Penny Levikis examined parental responsiveness at 2 years of age in a very different cohort. So this is a cohort of 246 children who were all slow to talk, so they were all late talkers at the age of 2. And she demonstrated that using a brief 5-point rating scale of parental responsiveness, which she's developed, called the Paris, it's a rather wonderful thing, she found it was a strong predictor of language at 3 and at 4 years in this slow to talk group of toddlers. So she was able to start to unpick which of these kids that are going to get better on their own and why are they getting better on their own, as it were. And then she came to work with me and James, so she got a Marie Curie fellowships, and James and I supervised her to think about whether or not this tool could be used in clinical practice. And so she developed some training and she trained health visitors, and she was able to demonstrate that health visitors, so anybody who's not from the UK, that's a group of community nurses who are highly specialist practitioners who work in public health in the UK, she was able to demonstrate that they can be trained to reliably make ratings using her Paris scale. So we were quite excited about that as well. And in 2019, we had the opportunity to take these ideas about developing risk models into the real world. So this idea of integrating child, family and parental factors and accumulating and clustering risks, can we bring them together to support identification of children? And this fed through to a study that was funded and commissioned by Public Health England, called the Early Language Identification Measure and Intervention, or the ELIM-I. So PHE commissioned the development of a tool for health visitors to use at the 2 to 2.5 year Healthy Child Review to identify children at risk of language difficulties. As I've said, health visitors are highly skilled nurses who work in the community and who support every family. So they're a universal intervention, health visiting is. They work with every family to promote the children's health and development. And I think they reach around between 94 and 97% of families in the UK. So it's pretty amazing what they do. They have a set of mandated visits where they have to visit families at particular times, and one of which is at the 2 to 2.5 year review. And what we did was we tested the optimal combination of measures for predicting language outcomes in a real world context. So health visitors were asked to, were trained to assess a various number of domains and use different test items to look at children's development. And then researchers tested the same children using a gold standard language measure, and they were blind to the results of the health visitors' outcomes. And we looked at which of those health visitors' tests best predicted the gold standard outcome. And then we put those together to create the ELIM-I. So the measures were a parent reported vocabulary checklist. Some of you who have been working in language development for many years will know it very well. It's the Sure Start language measure, which is a 50-word checklist, which James Law developed a number of years ago for use in Sure Start. So it's that parent-reported vocabulary checklist, and it's in combination with practitioner observation of the child's communication and related behaviours. So there's factors like the child's attention and concentration, whether it's fleeting or concentrated, and also some parent-child interaction observations. So we found this measure finds almost all children with low language. What it yields is a sensitivity of 0.98 and a specificity of 0.63. So it, as I say, it finds almost all children with low language at this age group, but it over-identifies some children who do not have difficulties. So it's not a perfect test by any means, but there's no such thing as a perfect test in the preschool years, I believe. And but it does. It is better than it's more accurate a measure than the measure that's actually in mandated practice across health visiting services, and that's the Ages and Stages questionnaire, and it's actually significantly more accurate than the Ages and Stages questionnaire. So this was an attempt of taking all those ideas that we developed in cohorts into the real world. There's more work to do, I think, in this space, but it's a first attempt, and I think it has proven to be helpful. So as a result, the ELIM I has been rolled out across England. So the Public Health England trained all health visiting teams to use it, and they chose whether or not to use it in their services. Okay, so now moving to interventions, clearly there's no point in identifying children without the provision of effective interventions. And in fact, it's highly unethical to assess children and then say, on you go, we're not doing anything about that. We've just noticed that you've got a problem and we're not going to help. But it's not really clear what these interventions should look like in the early years and within the systems that we work within. So alongside the developing the ELIM measure to identify children at risk, we also developed an intervention to be offered by health visitors when children were identified. Excuse me. So to do this, we reviewed intervention evidence to identify what works, first of all, for children in this age range. So we reviewed the research evidence and we pulled out what the active ingredients were of these interventions. And we spoke to stakeholders, we spoke to parents and practitioners to ask them about what was acceptable, feasible, effective and equitable from these interventions. And we followed latest guidance on intervention development, which involved large amounts of co-design methods with these stakeholders. And we drew on implementation science theory to develop a new intervention. So as I say, through multiple rounds of co-design, multiple rounds of co-design, and in partnership with BBC Tiny Happy People, we produced a set of intervention resources and training which were judged to be feasible and acceptable to families and parents and caregivers for use at the 2 to 2.5 year review. So in fact, they weren't just feasible and acceptable. Parents and practitioners were really excited and really keen to use this intervention and really wanted an approach which meant that they could get started to support their child. So the intervention that we came up with aimed to support families to increase their use of responsive interaction in daily routines. And as I say, it was judged to be feasible and practical and also exciting to families. They were excited by the idea. What we found was that families wanted really clear models of precisely what behaviours they were aiming for. Just telling people what responsive interaction was too abstract. Some of you may know about some of the other interventions in this space which use analogy, talk about the idea of serve and return in responsive interaction with infants. And what we found with the parents is that they just said, we've got no idea what that actually looks like or how you do it in the real world. And so we worked with BBC Tiny Happy People to develop a big library of videos which model the 9 key behaviours that we're aiming for in the intervention. So here's one of these, hopefully, videos. Hopefully we'll have some sound to give you an idea of what these look like.
Look, we've got matching socks. Now they can go in the wash.
Mummy's blue socks.
We're going to put them in the wash, aren't we? Good girl, Mummy socks in the wash. Look, we've got matching socks. Now they can go in the wash.
Mummy's blue socks.
We're going to put them in the wash, aren't we? Good girl, Mummy socks in the wash.
Okay, so we've got a suite of these little videos that support families to understand what it is that we're aiming to do in the intervention, and the paper resources that are given out by the health visitors scaffold the practitioner through the intervention with QR codes to help them to go to see the videos that are required to help with the intervention. And all of the messaging, this idea about being a super communicator, that's all been tested with families and was something that families found was helpful and acceptable. So the other aspects of the intervention that really strongly came through was we found that for the intervention to be equitable and not widen gaps between families, we needed to design its delivery to have the ability for it to be proportionate, so to be delivered with higher intensity for higher levels of disadvantage. And again, we designed that into the approach and designed in guidance for health visitors to make some judgments about who would need different levels of support. It also needed to be tailored so that it was offering different approaches to different families, considering the specific barriers and enablers in place for the different families. And we also found it was really important. We found that alliance and trust between the practitioners and the families was really very fragile. And what we needed to embed within the training and within the approach was approaches which acknowledge the strengths of families, and they're vital for maintaining relationships with the families. And also we had to embed shared decision-making approaches in there to go some way to challenge some of the power hierarchies that are at present between practitioners and parents and families. And so we built those approaches into the intervention design. So what this work pointed out for us as we were developing the ELIM intervention, it highlighted for us a really significant mismatch between the available evidence and the context within which the evidence needs to be implemented. So if and how interventions work doesn't just rely on the interventions themselves, but also on the systems within which they are being enacted. And it was really clear that it's not just their effectiveness which can be affected, but also their equity. So issues associated with real-world implementation have also been evident in other intervention work that I've done here in the UK and in Ireland with Beth, and happy to talk to other interventions that I've been involved in. And also when looking at a number of systematic reviews, it's really clear that there's a mismatch between the research evidence in this early years space and what can actually be delivered. So there's a real gap between what we know or what the research evidence tells us we should be doing and what we do in practice. And due to this mismatch between the design of interventions and research and what is really implementable within complex, diverse and overstretched services, these challenges emerge all of the time. So there's a real challenge in terms of the time and the capacity available to deliver the intervention dosage, which is prescribed within the research evidence. There's a real lack of specificity within the research evidence in reporting what interventions actually are. So it's really difficult for practitioners to translate that into their real world practice and deliver it with any high level of fidelity. And there's a real mismatch between the populations who are present in the research evidence and those who are requiring support in practice. So the majority of populations in research evidence are quite high SES populations and are almost entirely monolingual English speakers. And that's certainly not the populations that we are working with across the UK. So there's a real problem there. And also there's often really underspecified or unfeasible models of training. So sometimes the intervention is described, but there's no model for them skilling up practitioners to be able to use the intervention, or where there is a model of training, it's impossible for early years settings to actually free up the time for people to do that training, as it were. So there's a real problem with these gaps between the evidence and what we can do that were pointed up through this work. And so this mismatch has led to my fourth theme in my work, which is exploring how to deliver equitable and effective service provision. So thinking more at a systems level here. So the services which support children and families in the early years are very complex ecologies of voluntary, statutory, and private bodies with variable and distributed funding and governance structures, and they're delivered by a mix of health, education and social care professionals. And they're all influenced by often quite unconnected bits of policy that don't necessarily bring them all together as well. And so mobilising and coordinating the necessary resource in terms of capacity, skills and knowledge across these complex ecologies is really, really challenging. And it usually falls to local authorities to do this kind of work, who've had more and more of their abilities to control what happens in their local area taken away from them over recent years. So within these kinds of systems, interventions can widen rather than narrow inequalities for all sorts of reasons. It's more difficult for socially disadvantaged families to seek support and to navigate these complex and fragmented services and systems, and it's harder for them to advocate for their children's rights to education and health services. Also, many of the interventions, including my own, place substantial emphasis on supporting parents and caregivers to provide enriching home learning environments. However, it's obviously much more difficult for a family living with multiple challenges to provide these opportunities. So universal interventions trying to make this change happen run the risk that the families who need the interventions the least benefit the most if we're not delivered in a proportionate way. And an additional layer of inequity exists where families speak languages other than English, both in terms of accessing services and systems, but also because the vast majority of research evidence is entirely dominated pretty much by English language interventions. There's very limited research in any other language. And so there's another layer of inequity there for those families. So we've been trying to understand both how these ecologies differ and what makes them work. This is one study that I conducted a number of years ago using a case study methodology, where we tried to drill down into the detail of a local system in the UK, which was particularly effective at supporting children with speech, language and communication needs. And we were really interested in the relational aspects of this collaborative practice that was happening in this area. Now, what we found that was particularly powerful were kind of a set of norms of practice which we identified, which engendered trust between practitioners and facilitated a model which we ended up describing as being a negotiated, distributed and flexible model of collaborative practice. And it was this highly relational way of working together which seemed to be the key to make a difference to the success of this approach. There's obviously a more complex model there which you can read in your own time, but what we found was that the configuration of services doesn't always enable this approach, and that the teams in this local area were making really explicit efforts to make sure that they were creating these strong relational practices across the ways that they work together. So our work in this space about trying to think about equitable and effective service provision has been significantly hampered because people rarely describe the nature of systems and what they do in early years services, or if they do, it's a very top level kind of diagram of a process. There's not a lot of detail about how all these systems and services interact together. And so we conducted a survey of practice across Europe, which was translated into 30 languages and had 5,000 respondents from 38 different countries. And we asked them to tell us about their practice in supporting children with language difficulties. And the results are in this book here. And we triangulated that survey with a set of descriptive vignettes. So we asked these different countries to describe for us in a structured way what it is that they did to support children's language development. The vignettes were the most interesting thing, actually, not the survey, despite the 5,000 people. But what we identified was huge amounts of diversity across the different approaches across Europe and beyond. And what was driving this diversity certainly had nothing to do with research. It was rather methods of funding and governance and philosophical and historical stances regarding what child development and early education meant that seemed to be the primary drivers of this diversity. And most recently, I've been working on a GCRF funded project led by Professor Ghada Khattab, looking at supporting language development in Lebanon, Gaza, Jordan, and Egypt. And in addition to developing some assessment tools, Arabic and multilingual assessment tools, I've been leading a piece of work to map the provision of early childhood education and care and the place of oral language across Lebanon at system, structural and process levels. So, as everybody in the room will know, Lebanon has suffered numerous political and economic shocks in recent years. And Lebanon is a really proudly multilingual society and a proudly multilingual education system. It has the highest per capita concentration of refugees in the world, and the funding of education comes from NGOs, from overseas aids, and from the government itself. And it's one of the, I think maybe the most complex system that I've ever tried to have a look at. I won't talk about it in detail now, there isn't time, and I'm still doing the analyses, but what it really underscored for me and these vignettes is that if we're going to get intervention evidence into practice, we really can't be thinking in a kind of off the peg, what works kind of way. Here's an intervention, let's stick it into this context. We need to be looking at whole systems frameworks that are flexible enough but are principled enough that we can take the evidence and apply it into different contexts. And this is what led to the development of the public health framework. So all of this work that we've been doing led to the development of a public health framework for early language. And it's going to be a bit of a romp through because I've been talking for a long time. So I'm just provide a quick overview really of what this framework looks like, and I refer people to these two open access papers and this book for more detail and for a roadmap for implementation of this public health framework that Sheena Riley and I have developed and advocate for. So why have we chosen to use a public health framework? Well, for an issue to require a public health response, the following criteria must be met. It must place a large burden on society, the burden must be unfairly distributed, and there must be evidence that early preventative strategies could substantially reduce the burden of the condition. And I think it's clear from the evidence that has been amassed over recent years that early language readily meets these criteria. And furthermore, public health approaches fit the complexity of these ecologies that we were talking about. In those early years, public health interventions are enacted through coordinated action across agencies such as health, education and local government, rather than individual agencies. And certainly as soon as you get in the 0 to 4 space, this is necessarily invoked, that it's multi-agency work. Now, public health approaches have a focus on prevention, and prevention in these approaches can be enacted at 3 levels, at primary, secondary and tertiary levels of prevention. So primary prevention are these universal population-wide interventions, like, for example, the government telling us to eat 5 portions of fruit and vegetables a day, for example. Secondary prevention is aimed at subgroups in the population, and this can be targeted selective subgroups. So targeted selective is when you have a subgroup of the population who are at particularly higher risk of developing a condition. So for example, this might be breast screening in women over 50 because they're the group who are at most risk of breast cancer. Targeted indicated interventions are where an individual is starting to have early warning signs of the development of a condition, but they haven't necessarily got the condition yet in its kind of full form, as it were. So this, for example, of this might be high blood pressure being a trigger for some interventions to try to prevent later cardiovascular disease. And finally, tertiary prevention is where a condition exists already and is persisting, but the prevention is focusing on reducing the negative consequences of that condition and improving the quality of life and reducing experiences of disability for that individual. So what we propose is that if we are to address the volatility in children's language development, and if we are to address the need for sustained support and the inequalities in children's language abilities and early life experiences that we've described, then we need a mosaic of prevention, which focuses on identification, primary, secondary and tertiary prevention. And we need it to happen at multiple points over the children's trajectory between 0 and 4 years of age. And ideally, this mosaic should also be underpinned by connected data. So allowing children's trajectories and profiles of risk and response to intervention to inform action. Okay. So in order to describe this mosaic of prevention, we need to consider some essential components and some essential qualities, and I'll talk you through those now. So for primary prevention, we need a system of monitoring of language development at a number of points in development and at key transitions across services. And we need this universal messaging to promote awareness of the importance of language and guidance on supporting language development in daily life, at home and in early childhood education and care. And if this is to reach everybody, it needs to be delivered through multiple systems. So it can be delivered through broadcast and social media, but also through midwifery and public health contacts and early education and care provision. For the targeted indicated component of the mosaic, the subgroup of the population most at risk of poor language development are children living with social disadvantage, as I previously described. And so local services need to use their local data to target areas and subgroups and to deploy additional resource to those targeted areas and additional focus. In addition to this focus, efforts and enabling of the children's workforce, it's essential that we have national policy which tackles the upstream determinants of low language, including child poverty, overcrowding and unstable housing and unpredictable working conditions for families. So we can't lay it entirely at the door of families and local authorities. We also need national policy to address these issues. For the targeted indicated level, I think I've already described, this is where I think we need the development of risk models. So we're looking at not just solely looking at low language abilities in children over 4, but also looking at these wider contexts to see if we can identify children at increased risk. I think we still do need to be looking for children with these increased risks, because children with language difficulties do exist even in families who are not socially disadvantaged. And so therefore we do still need to be looking out for those children and integrating factors such as these that we've mentioned previously about responsiveness and social emotional development in children. And then at tertiary prevention, we obviously, these are for children with persisting difficulties. And so this needs to involve the provision of timely and sufficient specialist advice and support, which necessarily should involve a speech and language therapist. And these, the interventions need to address the children's language difficulties, but also be looking at the impact of the language difficulties on the child's daily life, working collaboratively with educators and parents and caregivers to address these more functional impacts on the child's life. And then looking at the essential qualities, then we've got these 4 different qualities that need to be running through the system. So the first is that essential quality is the idea that both the monitoring of children's language and the provision of support need to be developmental and sustained. So we need sustained monitoring to address this volatility in early language development that we mentioned before. And this allows judgment, and also to allow judgments to be made about this accumulation of risks over time and over children's development to be factored in to what it is that we do for families. The monitoring should be developmental in terms of the level of certainty that we can have about whether a child has long-term language difficulties and whether or not we need to consider wider risks. And the intervention efforts must also be sustained. So single, isolated early interventions, although effective in the short term, are not a silver bullet, unfortunately. Rather, we need to stack interventions over time and across services to amplify the effects of individual interventions. Secondly, we need to take a probabilistic approach. So we need to play the odds to meet the needs of every child. So the public health framework that we propose only works if all 4 levels of the framework are in place and are sustained for the first 4 years of a child's life. Because interventions and identification will always over and underserve to some degree, it's the balance across the whole system that makes it possible to meet all children's needs. Then the third essential characteristic is this idea of tailoring that we've mentioned previously in order to enable equitable benefits. We need to be proportionate in the amount of support that we're giving families depending on the level of difficulties that they're experiencing in their daily lives. And finally, we need this approaches to be co-designed so that they fit with the constraints and the assets of local services and can be delivered sustainably and effectively. Importantly, we need to be collecting data to examine the effectiveness of these adapted approaches, however. So I promise I've nearly finished. I'm just now going to tell you where I'm going next. So I've got 4 studies and I'm going to tell you what I'm doing next very, very briefly. So essentially what I'm doing next is to develop and test aspects of this framework through a number of funded projects. So first of all, with Lindsay Pennington and colleagues, we've got 2 current NIHR funded projects in places promoting local access to children's early language and communication and support. What we're doing is going through a cycle of supporting 3 local authority areas to identify the children that they're most concerned about, to choose an evidence-based intervention and then to adapt that intervention into the local context and then to evaluate whether or not that works. So that's an ongoing study. And then we're just about to start in May, a study that's going to actually do some evaluation of the implementation and clinical effectiveness of the ELIM that we described earlier. So we're triangulating data across a number of sources. We're also going to be looking at trying to improve the reporting of intervention research to support language and communication development in children. So we're aiming to create international consensus on how we should be reporting interventions in research to enable its more effective and timely application to practice. And my new colleagues on the front row are going to be helping us to do that work over the next 3 years. And then finally, we're doing a project which is funded by the Welsh Government, where we're developing a speech, language and communication pathway for Wales, where we're designing identification and interventions at 15 months, 27 months, 42 months to be delivered in both Welsh and English. So that's what we're doing over the next few years. There's much to do, but we're hopeful that we're moving in the right direction to develop effective systems to promote robust language development for all children. Thank you for listening.
Thank you. The wine is waiting, but Christina has said she'll take a couple of questions. We'll take a few in the room, and if there's any online, if you can put it in the chat, we'll come to you after we've done with the room. So let's start with questions or comments or reflections in the room.
It's too hot and tired.
Steve.
Just thinking where something like another with early language potentially fits in this kind of broader picture.
it's one of the components, I think, of absolutely. So I think classic Nelly starts at 4, doesn't it? And then Nuffield early language, the preschool one, is earlier. So it's one of the components, I would say. But I think what I would suggest is you can't wait till children are 4 to do something. That there's things that need to be happening in that earlier phase of children's language development. And unfortunately, those early years are much more complex than when every child attends a school. It's easier to get them all, but when you're in these complex systems, it's much harder to get something that's going to reach everybody. But I think it's a really vital component of a complex system. Absolutely, yeah. Thank you, Vicky.
Thank you, Christina. I had a question about ethics in relation to doing all of this research and securing consent.
Yeah.
Because one of the, obviously, as responsible researchers, we must and should seek a consent for participating in studies like this.
Yes.
But when you were talking about the equity issues, how do you handle that in relation to only families that can sign a consent form are the ones that get into your studies? And so is it then ethical to do research where only that cross-section of the population you're interested in is actually the group of people you investigate? How do you navigate those complexities?
Well, we need to try harder, is what I would say. I do think it's unethical to only have particular groups of society in our research. And, you know, certainly in the NIHR studies work that I do, the level of PPI, public patient involvement, in the design of the studies is incredibly high. And I think you can be creative, but you have to put effort and work into reaching those families. And I think in the Places study, we definitely are reaching those families. And the way that we've done it is by really extensive consultation with families and practitioners about how do you reach people, and spending time in places where families are in contact with services to engage people's trust and properly explain the nature of the research. So I think we need to try harder. We need to acknowledge that it's vital. We need to acknowledge that it takes time and money to do it, and not just do and push back to research funders to say, if you really want families to be evident in this research, you need us to give us the time and the money to do it properly. That's what I would say.
Good.
I like your framing around public health, and indeed public health crisis, we could say. But when you talk about primary, secondary, tertiary, it also had a sort of developmental feel to it, that the primary stuff, the primary prevention always comes preschool. But do you see those levels actually working later on as well? But you're focusing on the very early years.
I'm focusing on the early years, yeah, because that's where my research is. But I think it is absolutely can move up the development and into schools. I think what happens is the amount of resource that is at each level slightly changes. So I think you always need it all, but you need probably more in one area early and more in another area later, as it were.
The worry could be that the prevention is only seen in preschool years, and then kids who are a little bit later emerging their difficulties once they're into school are then forgotten about because they're not early enough.
Absolutely, no, I completely agree. But I think if we're overly simplistic and we say universal prevention's earlier and then we do a bit of that later and then that's when we get inequities that I was talking about. So we do need all of the action happening all of the time, but in differing levels of intensity, I think is probably, the right thing. But you're right, it needs to go across school. And I think it's a helpful model, I think, even within education, and particularly in developmental language disorder, because I think it sort of takes the idea away that we're going to cure anybody of having a developmental language disorder. It means that we're acknowledging that these are lifelong conditions and we need to be looking at prevention in different ways for those individuals. Yeah, absolutely. Yeah. Thank you.
Oh, thank you, and congratulations on developing such a clear framework.
Oh, thank you.
Question about risks. First of all,
Yes.
you've highlighted risks and how risks go together, and essentially talking about correlations there. So I wondered whether you'd done any modelling that might be able to help understand what the priorities are for intervention. That is, you know, if language is in your model, what goes away, what stays, or vice versa. And then second, and it's sort of related to Kate's question, it's about, is there a danger by calling this a public health framework that actually education doesn't engage? Because clearly you're working with very complex populations of people who are hard to reach, whereas in education it's mandatory, so they're in the classroom. But is there a way in which education practitioners can actually get involved much earlier on?
Yeah, absolutely.
So that when kids go into school, it doesn't sort of have a stop and then start again because they realise actually they have got problems.
So, so I'll take your second question first because it's slightly easier, I think. The public health, yeah, you're right. Having the word health in it has a risk to it for people not recognising it. I would say if you go in local authority areas, they absolutely understand that that means education. And if you work in educational settings, they absolutely understand that this is about coordinated effort across education, health, social care, community, private and voluntary sector, and everybody understands this is about coordinated action, I think, in those early years. So you're right, maybe that calling it public health might have an issue, but certainly all of the areas that I work with understand that it's about mobilising educators as well, and educators are absolutely core to all of it. But if it's a PR problem, we can have a think about another name for it. But yeah, certainly in the early years, people definitely see that this is all about collaboration, I would say, in the UK. Your first question about, I think, do I understand it? If you put language in, does it knock out some of these other predictors? It does to some degree, but it doesn't completely. And I think you always need language in there. I'm not saying we ignore language. Language, obviously, a child's early language is an important predictor of their later language. What I'm saying is we need to sort of tip the balance a little bit more to be able to identify with these other factors, to be able to identify which children. In terms of what makes a difference for interventions, I put this in and took it out. So I did a piece of analysis, too much to say, piece of analysis a few years ago where we grouped predictors according to whether we thought they were not mutable at all, mutable by social policy, mutable by interventions with families. And we looked at the relative predictive power of those different variables. And unfortunately, they're not mutable at all. Ones are really powerful. But, you know, there's not much we can do about that. But there are things we can do about some of the others. And we actually found that the mutable within a family were the most powerful once you take those other factors out that we can't do anything about. So they were around this responsive parenting, TV viewing in the home, and sharing books. So they were the most powerful ones, and not only of language at 4, but also what happened after 4 in terms of children's trajectories. So yeah, we have tried to do that kind of modelling, and the ones that were in our mutable group were ones that had randomized controlled trials to show that we could actually change them in families. But I think we can get smarter with that, can't we? That lots of really good causal modelling, statistical modelling that we could potentially be thinking about within longitudinal cohorts that would help us do that better, I think. Yeah.
Thank you. We have a lot of questions coming online, but we have 2 in the room that I'd like you to first answer, and then we go online. Okay. So Gabriel had his hand up. So Gabriel.
Hi.
Thank you, Christina, for this fascinating and comprehensive program of research that you presented today. So my question is about the slide you presented early on, which bar graph or the risk factors for language development. Yeah. So unless I missed it because the font size was not very big from where I'm sitting, I think you didn't have there the extent to which children attended early years settings like nurseries, and I think that could be potentially an influential factor, and I wonder why.
Because that's the nature of secondary data, as most people people who do secondary data analysis will tell you. Unfortunately, we don't have good data about that within that ELS cohort. But I think you're right; it is absolutely vital. We're collecting new data now, again in Melbourne, where we're looking at the quality of early childhood education and care between 3 and 4 and looking at long-term outcomes. So we're getting that data. But there are other studies that it's about quality, not quantity, isn't it, which makes a difference. And this is where we're very worried in the places intervention that we're doing. We're worried about the direction of travel in UK policy, that it's fantastic that we are getting more and more places for young children in early childhood education and care, but what we're hearing more and more is that the early childhood educators, there's not enough of them who are well trained enough to deliver high quality childhood education and care. So I think there's going to be a massive expansion with a whole group of early educators that potentially need a lot more support to be able to deliver what children need in those classrooms. But yes, I think you're absolutely right, but we weren't able to test it in this particular cohort.
Trevor?
Yeah, thank you. It was fascinating. I'm just interested in whether research that's come out since the pandemic, as a result of the pandemic, has fed into your work and altered the way you're thinking, or whether that is seen as a completely, separate cohort that had a very specific problem, and whether then the work that you're doing can continue to work with those children, or whether they're something else has to happen with them.
Well, I think what Cecilia might be able to stand up and tell us more about this. You've done lovely work in this area. But what the pandemic clearly demonstrated is that environment matters, and that early childhood education matters, and that early socialisation matters for families. It's a horrible natural experiment that clearly demonstrated how important early interventions and support for families are. Whether or not they're a completely different cohort, I don't know. The work that I'm presenting is all pre-COVID-19 pandemic in terms of the results that we're presenting here. I think probably what we're finding is just that everything's sort of a bit dialed up, so that the risks of children with something that I'd love every practitioner to know is that if you look at children's language and you look at their social, emotional, behavioural development together, those two things are really powerful in terms of deciding who needs help and support. And if you go into early years classrooms right now, they're telling us that those are the two things that are really problematic for children who've lived through particular sensitive periods under the COVID-19 pandemic. So I think the interventions are still valid. The interventions still work. Maggie can tell us about this. The interventions still make a difference to COVID-19 affected children. They still can make change happen. And so I don't think it changes the scale of the need, I think, and it brings into focus the need to look at both language and social, emotional, behavioural difficulties together, I think. Yeah.
Thank you. The question here on multilingualism,
Okay.
would you like to start with that?
How could it be added more explicitly to our models? That's a massive challenge. We're not very good at it in the UK, I would say. We're pretty terrible at it in the UK. According to policy, so the idea of what's done and what actually happens in practice are two entirely different things. And again, this is something we study. We are working in an area with a very diverse population in one of our local authority areas, and we're looking at to what degree can we modify the intervention to make sure that it's not just delivered in English, but that home language is a component of what's happening for their bilingual children and families. And it's really challenging. And although areas, I won't name the areas, they're amazing, but the areas that we work with and practitioners will say, this is in our policy, we deliver blah, 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 blah. We deliver support for people who are multilingual. The reality is that there isn't access to interpreters, there isn't access to support to deliver it in home language. So what people tend to do is say, we'll just deliver all our support in English because that's the language of instruction in schools, and so we're just going to crack on and deliver it in English and sort of ignore what happens at home. Whereas, as we know, the research evidence suggests that you need to support and enrich the home language as well to create gains for those individuals and keep them connected to their communities. So I would say it's in there, and the work in Lebanon is obviously really informing in a very challenging way my thinking about how you embed multilingualism and diglossia and other things within these kinds of systems. So it's in there in a principled sense, but in terms of how you make it happen within systems, I think it's still very challenging. And we maybe need to talk to other colleagues in this room to
You
address
have a
it.
question from Victoria. I'm not sure if any one of you want to come online, put your cameras on and ask your question. Otherwise, this is the question on, we thought about how to look at impact of flexible preventative intervention and the amount of engagement from families is potentially going to be less known.
Yes. I think I understand the question. Yeah, certainly the model that I'm presenting, Sure Start would be a part of that model. So it would be a part of a targeted, indicated intervention. Sure Start would be a part of that because it's looking at, let's say in Wales, we've got Flying Start, which is delivered to the families living in the 20% most disadvantaged families. They've still got Flying Start in Wales, and that is part of the targeted indicated component because it's targeted at socially disadvantaged families. And what we're doing is looking at how to make the maximum use of that provision that's being offered by Sure Start. I mean, the recent research shows that it makes a huge difference, doesn't it? Our most recent outcomes that Sure Start does make a difference, and I think it's the perfect platform on which to place interventions for language. I think there's a difference between a service delivery platform and what actually happens in that service delivery platform. And I think Sure Start is the platform, and we need to make sure within that robust language development is a focus and is supported. Does that make sense?
And there was an earlier question on how do you balance voices in terms of making your decisions on which are the best interventions to offer in the places project.
So in the Places project specifically, what we did was we looked at what actually have robust evidence, so randomized controlled trials in 0 to 3 space. So the focus is on actually in 0 to 3 years of age in places. And we actually ended up with only 6. There's only 6 studies that have got really good, robust evidence behind them. So there's a lot fewer than people imagine. And then we said, here's the interventions, choose one. And they chose one. And then we've been working with the intervention developers and the people locally to see the degree to which it needs to be adapted to be able to work in practice. And the choice was often driven by which children they particularly wanted to target. So the first stage of the Places process is to say, who are you most worried about in your area? And then the next is what might you mobilise in terms of children's workforce, and then choose an intervention. And so, as I say, there were only 6 interventions that actually have got good evidence. What we found is that we actually failed. We've had a failure in a second run in one of our areas. So we had a go, and the intervention that they wanted to put in place was so rigid that it was impossible for them to actually make it happen within their context. And so we've changed to a different intervention which got a higher degree of flexibility. So I think there's something for us as researchers who are developing and evaluating interventions to really think about, well, there's lots of challenges there, but I think thinking about what actually is vitally important, what are the vitally important components of an intervention, and are there multiple ways of getting this intervention into practice that could still bring about change. So I think some people think I'm being quite wishy-washy there. I am absolutely an empiricist and a believer in the randomized controlled trial, but also we need to move forward into more pragmatic trials, I think, and then also into more implementation of the evidence in the real world with ongoing evaluation. People are looking tired over there.
Thank you, Christina, for this fantastic presentation. We'll all be looking out for more work from you.
Thank you.
And do join us for wine and noodles and more questions to Christina. Thank you.